Is This Normal, Doc? A podcast sponsored by Tanner Clinic. Welcome back to another episode of Is This Normal, Doc? I'm Hope and I'm your host, and today joining me is Victoria as my co-host. Our guest on today's episode is Dr. Dan Sumko, and I'm going to give him the opportunity to tell us a little bit about himself.
Well, thanks for having me, guys.
Oh, yeah.
I'm entering my 4th year of practice here at Tanner Clinic. I specialize in hip and knee replacements.
As you can see.
Yeah, brought some visual aids, but yeah, I grew up mostly in northern Utah and did some of my training for medical school in Texas, and then I was back east for residency in Pennsylvania, and then I did a 1-year subspecialty fellowship year in hip and knee replacements in Phoenix, Arizona. And so after that, we got an opportunity to come back here and practice at Tanner Clinic, and we've been loving being back in the community where both my wife and I grew up. We have 4 boys from 13 down to 5. And so lots of family activities and things like that. But we've loved being back here and being in this community again.
Awesome. Well, we're glad to have you. And you guys can tell he knows what he's talking about. He went to a lot of school. So that's how you know.
Hopefully.
Okay, we're going to do a new segment that we like to call Is This Doc Normal? Okay, are you ready?
I'm ready.
We got some questions for
Okay.
you.
My first question for you is, what is your go-to karaoke song? Because mine is literally anything by ABBA. So
Karaoke for me is pay. I love to sing around the house and in the shower and things like that. I feel like I'm singing all the time, but getting up in front of people and singing is
hard.
It's I think I've done karaoke. I love to go to karaoke, like on cruises. I go to karaoke all the time, but I just creepily sit in the audience and watch. But I think I did Piano Man one time in front of my family under a lot of pressure, and then YMCA I did once just because it's kind of just like talking. Yeah, I did one time singing the OR and it kind of bit me. I had seen school was ending about a year or two ago, and there was a funny meme on the internet that I was telling my PA about where it said, it was like teachers the last week of school, and it had Lady Gaga doing this live performance of the end, and so she's singing, I'm on the edge, she's like doing this crazy, she's got her hair all crazy, and so I told them this story and did that impression of Lady Gaga singing, and I called the next day and check on my joint replacement patients and just say, hey, just checking in. Do you have any other questions? Are things okay? Oh, no. So I called this lady, and sometimes when you're under spinal anesthetic, which we do for these joint replacements, you don't feel anything, but you can hear, conversations. And so she goes, I just wanted to thank you so much. That was so sweet what you did. And I went, oh, what do you mean? I don't know what you're talking about. And she goes, yeah, your new knee? And she goes, no. She said, I don't know who told you that Lady Gaga's my favorite artist, and I was so nervous about that. And my favorite song is the I'm on the Edge or whatever it's called by Lady Gaga. She's like, I heard you singing that so well, and it was just beautiful, and it just brought me peace during the procedure. And I was like, oh my gosh, someone heard me doing that during surgery. I was so embarrassed, but anyways, she really appreciated it. So I'm real careful. I don't sing in public very often. Yeah.
I love that story.
To avoid embarrassment. No, man.
My question is, who's your favorite fictional doctor?
I think I'd go back to the days of Scrubs with Turk and JD, those guys.
They do have a musical episode.
Oh, yeah. Yeah, they do. They sing. But yeah, I think my wife and I back in the day, even before, I think that was before medical school and everything, we watched that show, and those guys are funny. House is probably too mean and callous and things like that, but he's entertaining. But I think those two would probably be the ones I'd like to meet in real life or spend time with more than anybody. So
that's a good answer.
all right, what snack do you keep in your office? Because mine is usually a hidden secret treat of peanut M&Ms. So what do you like to keep in your desk?
Mine is Red Bull. In fact, for Christmas, my PA got me a little Red Bull fridge, like on the counter at a gas station. Office is aglow with the light of a Red Bull fridge, and gets stocked at all times. So, come in my office sometime if you come to see me, and I'll show you my Red Bull fridge. It's pretty fun.
I might borrow some. Our last question is a would you rather question. Your question is, would you rather fight one horse-sized duck or 100 duck-sized horses? And I can tell you my answer, but you tell us yours first.
I don't think I want to fight a horse-sized anything. I think I'd go for the 100-horse duck-sized horses and take my chances there.
Really? I was going to say the one horse-sized duck, because if you have like a lot of little things around you, they could potentially
overpower you.
And especially if it's a horse. But then if you have one big one, you could like lasso it. I don't know. That was my thought.
Yeah, but did you know ducks, they're like pretty vicious sometimes, depending on
That's what was scaring
species.
me.
So if
That
it's a horse-sized duck.
Let's get into the topic for today, which is joint replacements. I want to start out by kind of doing a myth debunk. That was a tongue twister for me, apparently. And that myth is joint replacements are only for older people. What do you have to say about that?
More and more, we are doing joint replacements in younger people. Our technologies are getting better. The indications are kind of changing. I think the youngest joint replacement I've done is mid 30s at this point, but there's certainly joint replacements being done in even younger people. During my training, one of our attendings or people that are teaching us and training us was partially an orthopedic oncologist. And so she was doing joint replacements in teenagers and things like that, people who had cancer that had destroyed part of their joint, and there was really no other option for them. So it's not something that I love to do, but it is an option for people who are really struggling and miserable.
Yeah. I didn't even think about cancer being a cause for a joint replacement, but and that's coming from me who doesn't,
Certainly rare, but it happens.
Yeah. Besides cancer, what are some other causes that would require someone to get a joint replacement earlier in life?
So I think one is, prior trauma. We call it post-traumatic arthritis. And that doesn't mean you have to be in a car accident, but that could be one. But maybe you tore your ACL and you had your ACL done and it tore again. Maybe I've seen a patient who had 2 ACL surgeries and then got an infection on one, and the bacteria is actually hard on the joint and toxic to the joint and developed arthritis for that reason. In the hips more so, I see things like avascular necrosis. So or AVN is the short abbreviation for it. What that means is in the femoral head, this is your ball and socket joint of your femur, the blood supply to this area gets congested and decreased, and the head portion will die. That can be related. The most common reason it just is for no reason. But other things that can cause it are things like high steroid uses. So maybe someone has lupus and they're on steroid for years and years.
I have that.
I don't mean to scare you, but being on...
I was on steroids, but for a short time, so you're fine.
So steroids, alcohol use, smoking has been related. Deep sea diving, interestingly enough, the changing of the pressure can cause that condition. But people will come in and they're young and they don't necessarily have arthritis. Like in this model I brought, this is trying to show you, worn cartilage. Their cartilage will be good, but underneath the cartilage, the head has died and now it's become kind of, it's soft and hurts to walk on and things like that. So those are kind of the main reasons that people are getting joint replacements younger and younger. It's interesting when they do studies about what causes it. You'd think, like someone who's bigger, like obesity, that'll be a clear cause for early arthritis and things like that. Some studies yes, some studies no. Prior sports and things like that, some studies yes, some studies no. But the most conclusive one is usually just genetics. And so a lot of young people come in and they say, I'm 45, but my mom had her knees replaced at 42 and my dad had his done at 48 or whatever. And sure enough, they kind of follow the pattern there in the family.
Genetics really gets you.
Yeah.
It stinks because you should do it, you got it.
Yeah, exactly.
How would somebody know if they need a surgery or a joint replacement? Like, what are the common differences between those two?
That's when we're talking about repairing or, not doing a replacement. It's usually the hip, it's the labrum, and sometimes the cartilage. If it's like a focal spot or defect, if that makes sense, right? If the whole joint is worn out, the cartilage is gone, you need a joint replacement. There's really not much we can do. But in the hip and knee, if there's a focal spot that's worn, we can go in and do like a cartilage graft.
Oh, cool.
Otherwise, in the knee, you have the meniscus around the outside. I don't have a meniscus on this model to show you, but the hip labrum, it's kind of a cartilage structure that lives around the outside that increases the kind of suction fit of that ball and socket joint. If you've torn those, either the meniscus or the labrum, and the joint itself, the cartilage is pristine and perfect, we can go in and kind of repair and try and save that.
And do you see that in like an MRI, CAT scan? Like, is that how you tell the difference from if the cartilage is
Great
still
question. Yeah, we'll do an MRI oftentimes with some contrast dye, and to help us further kind of delineate what's going on there in the labrum and the hip, and see. And so I have a lot of people who are kind of this gray area. Fortunately for me, I have Dr. D in my office right across the hall, who's a sports expert. She does all the kind of scope stuff. And then he'll send, so I get people from him who they've had their hip scoped twice for labral tears, and now they've developed some arthritis on top of it, and they're only 45 or whatever, but they need a joint replacement. And so the studies are telling us more and more, don't just say, we'll get an MRI back that says, yeah, pretty severe cartilage wear and tear and a meniscus tear. And people get kind of hung up on that. Well, I have a tear of the meniscus. My friend had a scope. I should just have a scope. And I talk to him and say, we can do a scope, but you're going to continue likely to have pain from that cartilage wear and tear, and then arthritis that's in the joint as well.
I'm a little scared because I need a shoulder surgery, and I'm like, well, am I gonna have to get my shoulder? I know you're not a shoulder specialist, but I'm like, oh, maybe that's coming for me one day.
Yeah, there's a chance. There's always a chance. You worry once you start going down that road.
Yeah.
So we got a question on our social media from someone, and they were wondering, what are some signs that I should go get my hip or knee checked? And who should I go to? Should I go to ortho first, or should I go to sports med?
If you're experiencing, pain, popping, we call them mechanical symptoms, popping, clicking, catching, locking, things like that, swelling, instability, and you've tried, I think I would first try the basic stuff, ice and rest and modify your activities, try some anti-inflammatories. But if these things are persisting, I think the safest thing to do is to go and get checked. As far as the second part of the question, I get referrals and people sent over from, primary care providers or sports physicians, and there's different levels of comfort in those different providers. And so some will come over and say, I've been seeing my primary care doctor, and he's already done injections on me. He's tried prescription strength anti-inflammatories. And we got these x-rays that didn't show anything, and he also ordered this MRI. I mean, he did all the stuff that I would have done already. Other times I went and, I called my primary care doctor's office and told him I had knee pain, and they just said, go see ortho. And I'm fine with either one. We're happy to see either. But yeah, I think it helps to some degree to come in and be able to say, this started 6 weeks ago. During those 6 weeks, I've tried this, and that, and it kind of helps steer the conversation and where we go with the next step if you've tried some basic stuff. But at the same time, if you're losing sleep over it and worried about pain or symptoms going on in your joint, then we're happy to see you. Just come in.
Either way.
Yeah.
Do you feel like people put off going to see a provider because they're like, oh, maybe the anti-inflammatories will work, and then how long do you think people live with those symptoms until they finally say enough's enough?
I think there's similarly a spectrum there too. Some people, they can probably come in too soon without trying things, and then the other times you have someone who's just, I feel like a lot in this area. There's a lot of kind of, I'm a tough, farmer or whatever, and I
do like an active.
Yeah.
person.
Oh, yeah. Exactly. Yeah. I'm going to ski through the season no matter what. So I'm just going to go. And so I see a whole spectrum in that regard of.
Is there like a sweet spot to come and see a provider?
Right. Yeah. I would try those basic things I kind of touched on earlier as far as ice and rest, anti-inflammatories, doing something different. If it's something in the gym that's hurting, can you modify that activity? But if things continue to get worse and worse, then definitely jump on it and get it seen earlier than later. I had a mentor who was really good with patients, and he would say, this problem in your hip or knee or whatever is going to declare itself, meaning we're going to try all these different things, and either you're going to go down the path where you get better and better and we don't see you anymore, or you're going to go down the path of, it's just not responding to anything. And then do we need further imaging? Do we need some other kind of intervention, and eventually that road, at least for my patients in the hip and knee world, ends usually at a joint replacement. But I'm very conservative. I like to try every available non-surgical option before we jump to something like that.
Yeah. I think people like to hear that too. They don't want to just go straight into surgery.
Never want to push surgery on anybody, but once we've exhausted everything else, that's often what we're left with.
So I think one of the concerns that younger patients may have if they get a joint replacement now is they're worried that they're going to need to do the surgery shortly after within their lifetime, maybe 10 to 20 years. Could you give us a little bit more information about how the joint replacements work and their longevity?
That's a concern not just for patients, but for, the people putting them in as well. And so I quote people more like 20 to 30 years, I hope. But obviously there's outliers where it'll go much longer or potentially shorter. I was really hesitant when I first got into practice and doing joint replacements in younger people. I think a big eye-opening experience with me, I was sitting there, telling this gal who was young, early 40s that needed a knee replacement. I said, there's a chance you're going to, need this redone. You should try other things. We should put this off longer if you can. And she kind of, she was just at her wit's end and said, I would rather have 20 or 30 good years right now while I'm in my 40s, 50s, 60s than live those years in pain and debilitated and not be able to hike and do the things I enjoy. I'd rather have 30 good years and have this redone than to sit here and just be in pain and misery and unable to move. And that was kind of like a big, wow,
Yeah.
I actually get that. And I would have the same thoughts if I was in your case where, let's do what we have to get me back to my level of function that I need to.
Yeah. Do you use different techniques or types of replacements depending on the age of your patients?
Yes, I'm glad you asked. So I brought this for you guys to kind of look and feel. Oh, good. So the gold standard for knees anyways, the gold standard for many years and kind of still is to put these in with cement. And the cement acts as a grout. I can take this apart.
I never thought cement was a bonding agent
cement.
on bones.
Yeah, so if we would prep this, for the tibia, for example, here, we would prep this, we fill all these voids and surfaces with cement. It's, kind of like typically a white bone cement. Cover all the implant surfaces, and then we'd mush that down, impact it, scrape away all the excess cement, and let it dry under pressure like that. Now that's excellent and has done well for a really long time. There's some concerns with that. One is, you guys have maybe heard of, am I allergic to my joint replacement or am I allergic to metal? Yeah. Some people say that the allergy to metal isn't a really big concern, but actually the allergy to cement. So
just to clarify, this is not the same cement that we're using.
No, this is not. No, this is bone cement. It's the polymethyl methacrylate. It's a different kind of. Yeah, it's similar chemical agents to what bonds nails, acrylic nails, and so there's women who wear those who get bad reaction to.
Oh, that was me.
Okay, so you may have a potential allergy to cement, which they say is more common than having an actual allergy to metal. And so there's concern that interface between the metal and the cement and the bone could fail and debond and things like that. And I've seen that. And so an alternative potentially for younger patients is what's called a press fit or a cementless implant. So you can see this one's smooth and intended to bond with the cement and sit in the bone. This one is rough, and actually bone likes to grow onto rough surfaces like this. And so this one you would impact in with no cement. It would touch directly on the bone and the bone would grow into that, theoretically giving you, it basically becoming a part of your body. And so if that fixation point is solid and permanent, then you really only have this plastic bearing to worry about. So theoretically, could you put a joint replacement in a young person? They get perfect fixation of the metal to the bone, and then they wear this bearing out over 30 years. You could go in and just change the bearing, whereas if they wear out...
I'm guessing that's a little bit less impactful.
Absolutely, yeah. Yep, much less invasive and easier recovery to just have a plastic change than to have to go in and change all the interfaces with the metal to the bone. So, really good question.
Super interesting.
When you're talking about impacting.
Yeah, but
you really getting in there. We were just talking about some videos about
watching surgery.
Yes.
And I'm like, ah!
Yep.
I'm scared. You're out. You're not.
You're out. Yeah,
Awake
you're
during
not.
the
You guys? What about hips? Do they have something similar for hips?
Yeah. So cement in hips is much more rare. You can see in this model, both of these implants are covered with that more scratchy back, and so there is some indication to cement in hip. It's usually in more elderly people or people with certain kind of morphology of their femur where the stem won't fit properly and engage properly. Then you just kind of cement it in. And so I don't want to I don't want everybody in the world going, oh my goodness, I had a cemented knee. My knee is bad or the worst. That's not the case. But this is a kind of an emerging technology with potentially a better solution.
So we've been talking a lot about the process of a replacement. What does the recovery process afterwards look like for one of these younger hip and knee replacement patients?
That's a really loaded question. People ask me that all the time.
Sorry.
No, that's okay. And I usually ask them, well, what are you looking to get back to, right? And I explain the recovery of a joint replacement, the recovery time for someone who stocks shelves at Walmart is going to be longer than for someone who, works from home at a desk. And so I've had patients get a hip or a knee and they work from home on the computer and they wake up and they're back at work the next morning. They can sit at a desk and sit in their bed, with a little laptop thing and work. But for knees, I tell, and hips, I do 2 weeks of in-home therapy where therapy comes to see you. After those 2 weeks, most hips don't need formal physical therapy. They can just kind of start back to their activities slowly. Knees get 4 to 6 weeks of formal therapy. That's 2 or 3 times a week for a few weeks. Each joint replacement we do as outpatient setting at surgery centers typically.
Yeah.
You go home. I tell people walker for a few days until you're steady on your feet and your strength is good enough that you're not going to fall, and then you can get rid of the walker. And so I just try to explain to people there's different phases of recovery, right? Overall, I would call this a 1-year recovery. That's when the studies show us that you're healing and improving and making steady improvements for a year. But as far as getting back to work, that's going to be a different answer for each person.
Yeah.
Are you able to walk shortly after? I've seen on some of your social media stories and posts that you've had patients walking like the next day.
Yeah, that's the same. So people ask, how long do I need to use the walker? You walk out of the surgery center with a walker, and I've heard as short as, doc, they made me use it to get to the car. Because that's their requirement. Their policy. And I never use it again, all the way to, the longer, up to 2 weeks and things. But hopefully within a few days, I'd say the vast majority of my patients are off their walker.
Awesome.
And it's really just for safety. A lot of the home therapists, they don't want to have a fall or get them in trouble. So they push the walker more than I probably would, which is probably a good thing in the end. But loaded question, like I was saying.
It's always different for every person.
Yes.
Exactly. Yep. That's a frustrating thing. Is I'll do the same surgery on 5 people in a day, and I'll have 5 different recovery courses and 5 different levels of pain and things like that. And it's like, man, what you feel like you want to hit your head against the wall and say, what am I didn't do anything different, but patients are different, and that's just the way it is.
Yeah. Do you find ever that age has anything to do with the recovery time, or is it more just pretty general for everybody, or very specific to each person, I guess?
Yeah, it's still pretty specific to each person. I will say, I feel like little old ladies seem to do really well.
They always do.
Yeah.
Very resilient.
And it's kind of I remember being a resident and going in to check on something in physical therapy, and I could still see it in my mind. We had done this big construction worker, tattoos and the goatee or whatever, and he was sitting in, we had done a knee replacement on him, and then this 83-year-old gal, and she's literally doing circles around him, walking around, and he was sitting in his wheelchair, tears running down his face. I think it's harder on people who are big and muscular. You're retracting more tissue back. I think they swell more. Their surgeries usually take a little longer. It's a more traumatic process for them. And so it's anecdotal, but when I see a big guy, I recently did like a big, motocross rider guy in his 50s, I was like, I'm going to warn you, you're going to be hurting afterwards. You just have that makeup of someone who's gonna have a lot of swelling and struggle. So
Your body's working against you. You think you're all fit and healthy, and then it backfires. We're gonna do a rapid fire. Is this normal? So can you give me 3 red flags when it comes to joint pain?
I'd say major swelling, instability, and then painful popping, clicking, or locking. So I'd say I see a lot of people who say, I feel my knee pop every now and then. The first question is, does it hurt when it does that? If it doesn't, to some degree, that's normal.
So the fact that my body just clicks all the time,
Yeah,
and I'm just walking around.
That doesn't necessarily mean that you've got problems in your joints or things are damaged. And so I would say, I'll stick with those. Major swelling, instability, or locking, popping, clicking that's painful.
What are 3 things to expect when it comes to a joint replacement surgery?
A lot of work, especially with knees. Hips are easier, but I would plan on some work, some pain. Even though, I'm using muscle sparing techniques and things like that to minimize pain, I'd like to under promise, over deliver. So I usually tell people, expect a lot of pain. And then if they come back to me and say, it wasn't as bad as you said, doc, I'd rather that way than the other way. I'll put a positive spin on it. Expect some improvement and to get back to your life.
Yeah.
And that's one of my favorite things with hips, especially. People will wake up in the recovery area and say, oh my gosh, that stabbing pain I had in my groin for the last 5 years is gone. Or when I call people the next day after a joint replacement, they'll say, doc, I got my first night of sleep in years. And so it's not all doom and gloom. It's going to hurt. It's going to take work. But we're doing it for a reason, to get you back and to get you feeling good.
Right.
His job is to make you feel better, not worse.
Yeah.
So,
I'll try not to focus on all the...
Yeah.
but it is good to know what to expect too. But I'm glad that people are getting some relief from that pain, for sure.
Yeah.
I like to give you the opportunity to leave some of your advice and your wisdom. So what's one piece of advice that you could give to a young person that's experiencing joint pain?
I would say just try to take care of yourself. The more kind of pounding you do on a joint, the more you can wear it out. But obviously, I want you to be able to function and do what you want. But I tell people, if you have the choice between running on hard pavement and pounding pavement versus biking or swimming, things like that, if you're having joint pain, those activities that are less impact on the joint typically help people. But take care of yourself. But also, I'm a big advocate. One of the big reasons I went into orthopedics is I want to get people back to doing what they want to do. So just be smart about it and take care of yourself, take care of your joints, be healthy. Try to keep your weight under control and things like that can lead to damaging the joint.
Moderation in all things, I always say. Don't go too hard on anything, even if you love it. Sometimes you need a break, and your joints need a break.
What is the process like for making an appointment with you?
If you just call Tanner Clinic and get in with scheduling, we'll get you in. There's appointments with myself, and I'm in clinic typically with Skylar Gallegos, my PA, and so he has lots of appointments available. And so do I. We'll get you in quickly and seen and try and put your mind at ease or work you up further, whatever you need.
And then where can we find you on social media?
Most of my stuff is on Instagram. I do a lot of videos from the office with patients, kind of feedback and experience. And I've done some stuff on there about what a typical appointment with me looks like and things like that. But it's dr.dan.ortho. That's dr.dan.ortho. On Instagram, and then Dr. Daniel Sumko, hip and knee specialist, I believe, on Facebook.
I just want to close out by saying, if you are experiencing joint pain, I would highly recommend going in to see a doctor. Dr. Dan is great. He's so knowledgeable, and he wants to get you back to feeling your best. So I highly recommend making an appointment with him. And we're so happy that you were able to come today. Thanks so much.
Thanks for having me. That was fun.
Disclaimer: the information shared in this podcast is for general informational purposes only and should not be considered medical advice. While our podcast will provide helpful suggestions and insights, every individual's health situation is unique. For specific medical advice, diagnosis, or treatment, please contact your personal healthcare provider.